Welcome to the AI Ireland podcast, your window into the world of AI innovation on the island of Ireland. Join us as we explore how AI is harnessed to tackle both business and societal challenges, revealing the cutting-edge solutions emerging from this vibrant AI community. Don't forget to subscribe for the latest updates and insights in the world of AI. You're listening to the AI Ireland podcast. I'm very happy to be speaking to Peter MacMahon. Peter is a radiologist consultant at the Mater University Hospital, and this is because we've got the finalists of the AI Awards of Best Use of AI in Healthcare. Peter, thank you very much for joining us on the show.
Thank you for having me.
How did you get into radiology? How did your paths cross? What did you do?
Yeah, I mean, I have, I suppose, not a technical background, but I had an interest in computers from early on as a teenager, did some basic programming, different things like that. And I decided to go into medicine, but was looking for a technical aspect to medicine, if not possible. I had medicine or engineering as a kind of a choices for leaving cert type thing, and a little undecided until the end. But went into medicine and then realized within medicine, huge number of options, which is a great thing about medicine. There's lots of different things you can do within medicine. And one of the more technical ones was radiology. So that's where you're obviously acquiring x-rays or doing scans and then interpreting those images. And when I was joining radiology, or when I was going through med school and joining radiology, the radiology was becoming digital. And it was one of the very first things to go digital, where they, instead of having the classic floppy x-ray you put on the light box, it was becoming all digital and putting on computers. And the radiologists then were more interacting with computers than they were with the structures in the hospital. So that was appealing to me as an area of medicine that I wanted to get into. So that's how I really got into that.
So day to day, we were just actually, we had a guest before you who was talking about people, practitioners, clinicians are just under so much pressure. They're, in the guest before we were talking about 50% of documentation taken away from actually working with the patients. What were you seeing before and after, before you were able to start to use technology as more of an enabler to allowing people to do better work or more meaningful work or less, I suppose, more efficient, less errors? And was it kind of a night and day where you started to see tech really adding that value, or has it been a gradual kind of process?
Yeah, so I mean, everyone talks about AI being transformative, but one of the biggest transformations that happened in radiology was going to digital. And if AI can replicate what the impact that went to digital imaging had, it would be quite impressive. Because to go from plain film x-rays to digital meant that we had everything on one system. And we had all the priors as well on one system. So the classic problem we would have in the old type of radiology, where the hard copy films, was they go missing. They would literally go missing because the doctor would take them to the bedside. They would maybe take them to a ground rounds meeting and then forget them, bring them back, and they go missing. And so you literally wouldn't have access to a prior study. But of course now when everything's digitalized and it's put into one central database, you always have the priors. You always can do measurements very easily. You can zoom in, you can you can change the window or the brightness and the contrast of the image. You can manipulate the image, you can do some processing of the image. It was transformative for radiology to go to digital and allowed lots of different applications. It allowed us to, because we're using the computers now, we started to use voice recognition software very early on in radiology. So instead of speaking into a tape and having a typist to it, it was, I'd say, maybe 15 years ago where radiology moved to using voice recognition technology to do all our reports. And that's evolved over time. But all that together made it, the entire radiology experience essentially digital. And it just became, and this has probably facilitated the deployment of AI in radiology, because we're so early in digital. So we have huge database of digital information in radiology. All our imaging is digital now. And in the HSE, that probably dates back to 2010, that kind of time, of where everything is digital. And we also have text reports which are all digital. They're not printed on paper or stored in charts. They're all stored in the same database. So, and this is probably true across 99% of radiology departments around the world at the moment, is that everything is digital and we have a huge amount of data. But moving from analog to digital in radiology was hugely transformative and massively changed the way people approached it. It attracted different types of people into it who saw the innovation. They saw the things they could build on it, and people started developing AI tools very early on because all the imaging data was available. Very kind of primitive AI, wasn't like the deep learning type technology, was very early basic stuff, but already you got a taste of like what was capable now that we moved from hard copy to digital.
And from the patient outcome and improving that, you can only imagine ringing someone up to say, we've lost your record, can you come in again?
Yeah.
And the challenge around actually doing that, I can imagine the patient outcome would have dramatically increased.
Yeah, when you have, like for cancer, the classic one where it's all about change, so has the tumor got bigger, smaller, things like that, you have to have priors. It's like the best test is for any patient is having a prior study to see what's happened, what's changed. And when it's harder to access that prior and you're ringing around trying to find the priors, or in the physicality of it, that you have a prior study from 2010 and you one from recent one, and you're trying to find the exact same image slice, and you're using a magnifying glass on a piece of paper to look at it in close detail. Very hard to make measurements. It was very difficult in analog times to do these type of things, and so much easier now with digital.
So you've got a strong foundation because you have that digital copy. Talk us through the need for introducing AI. And I'm guessing you're bombarded with companies saying, can you trial this out? Can you give it a shot? And I'm always remind people, you're time poor, you're under stress. So to try a different type of experiment that chances are will probably not go right, you're going to drop morale and you're going to be less likely to go ahead with it again, particularly across the whole team. How did you start to feel more confident with introducing ADOC, lemur, these types of things?
Yeah. So we, and it's like that change process is really important to manage when you bring in an AI tool. In the matter was somewhat unique. So we started our dabbling in AI, inverted commas, in 2015. So and my particular interest in radiology, broad church, and I have a very specific interest within that, which relates to emergency imaging. So patients who have strokes, heart attacks, trauma, things like that, break a bone. That's my particular interest, and sports injuries. So all those, like, I'm less of a cancer focus and more of those type of acute problems. So, and I work in the Mater Hospital, which is probably the biggest emergency department in the country. And I could see that there's huge demand. We all know in the emergency department there's incredible demand on the service. Very hard to keep up with the demand, and people backlogged, and there's trolleys and different things. So one particular challenging area for us is stroke. So stroke, the key aspect of stroke is that if you, for example, can't move the left side of your body all of a sudden at work, and you're brought to the emergency department, the key for you to get best treatment is make a diagnosis as quick as possible. And I mean straight away. So the longer every minute, a few million neurons are dying. So this is like really, really time critical process. So what we brought in the Mater Hospital, a kind of a expedited care pathway for these patients. So you arrive by the ambulance and you go straight to the CT scanner. You go straight to CT. You don't, no waiting room, there's no like triage process, you're just going straight to CT. And you're trying to get them under the CT scanner in 5 minutes. And then we do lots of imaging. I mean, lots and lots we generate probably 5,000 images on patients as soon as they sit down. We do lots of different types of scans. They're quite complex and they're kind of time-based. So what we're doing is we're looking at the blood flowing through the brain. So it's a very complicated process, and we're trying to find out where the part of the brain is being deprived of blood. And so this is actually a really difficult problem for the human then to interpret. So you generate huge amounts of data, and it's all very useful data. And when you're doing research on it, you have lots of time to look at it. But in the acute scenario, you don't. So I went searching for some kind of assistance for the physician to do that, like a radiologist. And there was a company called Rapid, an American company in California, and they just made this bit of software to help us analyze this. It's called perfusion data. So it's 2015, very early days. And so I think we're one of the first in Europe to try it out. And it was specifically picked because it was an obvious problem for radiologists. We really struggled with this kind of clinical scenario where it's really, really time pressure, an awful lot of complex data coming at us, high risk scenario if we make the wrong call, the wrong treatment is given. So I went looking for a solution for that problem that I know people wanted a solution to that problem, rather than be foisting something on it and really wasn't going to affect them. So we picked that as a problem, we found a tool, and it really worked really well. And this is 2015, and we required a lot of coordination. You can imagine the early days, the data protection officer getting involved, the CEO being involved, the master IT department being involved in different aspects, law and the legal department and things to allow this data to be processed in this unique way. And so that's where early on 2015 we started doing that. And then we developed that further, and we did other types of stroke AI software. It was kind of rudimentary. It wasn't actually deep learning. It was kind of basic kind of computer-aided diagnostics. So it helped us make decisions. So that was already kind of testing the waters. And then obviously, say post-COVID, I suppose, where deep learning in healthcare really took off. And then we were kind of in a position where, okay, as a department, we're kind of used to having now a decision support tool available to us at the time. So it's a little bit easier for them to develop or to deploy a new tool. And that's how we got involved with the company called ADOC. And their company then provide additional solutions for the emergency department. So again, it ties in well with me. So I obviously particularly interested in that area. So they can look at things like clots of the lung, they look at fractures of your neck, they would look at blood in your brain. So if you have a hemorrhage or bleeding in your brain. And that software, what it does is, it analyzes all our CTs in the matter. So we've had it now deployed since, I think it's April of last year. So it's nearly 18 months now of having it deployed in the routine clinical environment. So every CT scan that is performed is analyzed automatically by AI, and it's flagging for emergency conditions. And so we're finding it really, really accurate, and it's really useful. It is not perfect. It definitely makes, I would say it's like 90% accurate, that kind of level. So 10% of the time is making a mistake, which is not insignificant.
Just a challenge, right? And again, you probably won't just know off the top of your head. So let's say you look at something today, but tomorrow, or hypothetical, Dr. A looks at something today and looks at something tomorrow, but maybe they're a lot more tired than they were today when they look at it.
Yes.
Would you say that's 90%?
Yes.
Would that be 95%, 97%? What would you say?
Absolutely.
Compared to the AI? Because I always think it's context with people,
yes,
how they're feeling, and then you've got a difference of opinion who might have a different.
Yeah, absolutely. I think by having the AI deployed, you kind of realized actually, in some ways we hold the AI to a higher standard than maybe it's fair. Yeah. Like for a human, we make mistakes all the time. We're tired often, and you're often being distracted, especially you can imagine the Irish healthcare environment, knocks on the door, the phone is ringing,
you got 5 minutes.
Yeah, and there's like all this data coming at you, and you have to make a decision, and you make a decision, you move on. And then you might look back to you, like, did I really look at all those images properly? And obviously having an AI, it just does the same thing every time. Yeah. And it's useful. And our most impactful aspect to the AI we have at the moment is that it's a wingman.
Yeah.
We regard it as a wingman. So
co-pilot.
So it's there out looking over our shoulder and going, did you see that thing there? And that last slice in that scan that you might have just not reached when you're scrolling through it, actually had something on it. Yeah. So that's where it's particularly useful. Like vast majority of the time, the human would have made the same diagnosis. Yeah. But at 2 a.m, especially if you're trainee, you don't have that expertise of looking at thousands and thousands of patient scans. Knowing you have somebody else over your shoulder looking at the scan and saying, I think it's normal. Yeah, you think it's normal? We both think it's normal? Great, next case. Yeah. That's quite reassuring and presumably safer.
And is it the case that it's still the clinician that's saying, I'm signing it off rather than the AI ate my homework, I put an AI, it's still the case of you're to sign off and it's the co-pilot and it's augmenting the decision?
Yes. So I think it's been a long, long time before we have an automatic process where an AI is going to be looking at a study and saying it's normal and nobody needs to look at it. It's certainly a potential thing, but there's a significant risk with that. The current AI, our experience, like we have lots of, I can't remember how many, we've nearly lost count, maybe 12 different AI tools in the matter, routine clinical practice. And they're often making mistakes. And some of them are stupid mistakes, right? So like, if you have one of our tools looks for fractures and it might be a catheter, urinary catheter, like a little tube that goes across the leg. Yeah. And they do an X-ray of the leg. It will look at this tube and go, oh, that must be a fracture. I haven't seen that before. Yeah. And flag it. And you're like, obviously it's not a fracture. Yeah. So it'll make stupid mistakes. But it's very easy for humans to often just go, disregard that result. Yeah. And so the combination, it works really well. Having a human who's sensible, who can look at the results, can make a help.
But you still need that human to know what's right and what's wrong as the foundation, rather than we don't need that human because they're going to spot that.
Exactly. Yeah. Now, the one of the interesting things that we're looking at now is everyone talks about bias in AI, but there's a huge bias in humans. We all have biases, but like the AI results definitely biases the human results. You can imagine, so we love kind of just certain results. We love a digital result. Yeah. And if you're, especially this is especially true for trainees. The trainee's looking at an X-ray, the X-ray is performed, and they go, I don't see anything. And the AI doesn't say anything. That's great. They move on. They go, next case, I don't see anything. The AI says something. The AI is flagging something very subtle on the X-ray. And they go, okay, right, let me, I wouldn't have normally called that, but let me just call it now instead. Yeah. And so now they're being drawn one way where they might be over-calling stuff that they wouldn't call before because the AI is not perfect, but they're going to trust the AI more than themselves. Yeah. And then the inverse, of course, is they think they see something. Oh, that looks suspicious. I think I'll call that a fracture. Well, the AI says there's no fracture there.
Yeah.
I'm probably wrong. I'm a trainee. I'm probably wrong.
Yeah.
I won't call it a fracture.
Yeah.
So there's very
Delicate balance
yes,
there, isn't there?
of getting that. You know.
So you've also got the trust that you're building up with it because it's been consistently right over those years, and then for that mistake to seep in.
Yes.
But then I suppose you know it's not fallible, so you've got that imprinted in your mind. One of the things that I've noticed from healthcare is the percentages or accuracy across the different divisions is so much lower. Radiology just seems to be primed for it in terms of really having that good foundation. From an impact level, let's say I'm going in and I'm getting a test or getting it screened. Maybe it takes me 45 minutes, an hour before using ADOC or Gleamer. What does it now take me, or what kind of impact do we know on a scheduling or a RODA?
Yeah, so I think at the moment, the way AI is being used and is deployed around the world, it doesn't, like a patient would be unaware of its impact because it's primarily designed to help people like myself make a diagnosis rather than the patient journey, right? So when you come into the hospital, so the minor injuries unit in Smithfield, and you go in there with because you can't weight bear on your ankle. You've twisted it, you think, oh gosh, I may have fractured my ankle. Yeah. You come in, you might have an x-ray and it might be read by AI as well as the human, but like the process hasn't really changed for the patient in that sense. Hopefully, you know, the accuracy of the overall process is improved, and what we're hoping is that we'll have if you look at a large number of patients, that the time to final true diagnosis is better when you have AI than not. Because we know humans miss things, but having AI there as well, hopefully that will reduce those misses, and then for the majority of patients are getting their correct diagnosis earlier. Yeah. Now, it has to be said, there's a huge lack of data in that regard, patient outcomes, right? So there's an awful lot of studies that look at diagnostic accuracy of radiologists with and without AI. Yeah. That's been done to death, and we all know there's a slight improvement. It's not dramatic, but there's always a slight improvement. So what we're now exploring in the matter is doing a proper patient outcome study. So take, say, for the fracture detection AI tool, that is a potentially very impactful tool because interpreting x-rays is really difficult, a very pressurized environment, often inexperienced people, the front line making decisions at 2 in the morning. So if an AI tool can improve the process, it could be very impactful to patients, and maybe the HSE should roll it out every emergency department in the country. But there's a huge cost with that. So what is the actual benefit? Okay, there's benefits to radiologists, they're slightly maybe faster, slightly more confident, but really does that justify the cost? So what we would like to do is an actual patient outcome study. It's very hard to do it, but we're discussion with UCD, discussion with all the emergency department in the matter, and we've recently had several meetings about this, but the idea is the patient will come into the matter emergency department and be randomized to getting AI or not. So they obviously be part of a research project, they'd be consented, and we'd say, look, we're going to record all your data, we're going to see the outcomes, we're going to see your time to diagnosis, your time to getting treatment to your fracture, and you can be randomized to getting an AI-assisted diagnosis or not. And we're going to follow the journey then beyond that, beyond their ED. Do they get to theatre sooner? Do they get out of their cast quicker? Do they, you know, they're not, you know, they're told to weight bear earlier than they used to be, things like that. And see if there's actual patient outcome improvement rather than just a radiologist improvement.
So one of the things I'm quite interested to do is, you'll obviously know the impact of no-shows and things like this, where you've got the AI making a call to the patient and saying, can you please confirm who you are? Are you still going to be able to come in? Can we make a payment online? Here's all the parking details, this is where you can park parking, any additional questions, and then a follow-up text or whatever to dramatically reduce this. Have you seen some of those products or services, or have you tried out any of those products or services?
We haven't used, I haven't seen that being deployed. I mean, we obviously have the analog version of that, of just a person calling, right? Yeah. Or you're having a very basic automated press 1 if, type thing rather than a conversational agent. Yeah. But you imagine it could be particularly useful because obviously no-shows are a huge pain for the hospital. You have 20 slots to do a certain procedure, and if you have 3 or 4 of them don't turn up, then that's a substantial loss to the system of what productivity could be gained. So I'm sure those things are being looked at and considered. There's a huge challenge in doing these things, a huge challenge. So in the matter for us to get, so we went live with our AI solutions, the modern ones, in April, but it was at least 12 months of work to get it to live. And that required a huge amount of coordination. And the largest amount of it, because they use the cloud, it requires Mater patient data leaving the Mater Hospital's IT network and going into, I think it was Amazon servers or Azure, one of those servers. And they're staying in Ireland, the data, because we're a lot of data farms in Ireland. It's quite useful that way. So it doesn't leave Ireland, but it's leaving the secure healthcare network. And that's obviously a kind of a risky process. And a lot of people were unsure, and a lot of people were initially saying, no, we can't do that.
Yeah.
So we had to get a lot of people on board, including the data protection officer, Ronan O'Halloran, has been very helpful and progressive in this way, and getting this across the line. Obviously, our solicitors in the matter has to be involved, looking at the contracts. And there's a huge amount of cybersecurity analysis of this data and this anonymization process and where it's going to be stored and would it leave Ireland and all those kind of reassurances need to be. And so these things, it sounds great and it sounds like, oh, just like installing an app, but it's so much extra work in healthcare because it's such sensitive data.
Yeah, and one thing that I was surprised, I only learned maybe 3 years ago, is health records are primed for people to want to get access to and try to sell them on and breach and really go for it. And even what I was even more surprised is if you could get like Tom Cruise's access to his records and put them online, the amount of money that you would have warrant, the amount of information. So there's so much focused on those different areas. So it's, if there's a vulnerability, they're going to really try to go for that as well. So you do have to try to offset that.
Yes. And I mean, when I first started trying to get Gleamer, which is the bone fracture detection software, before the cyber attack which happened in HSE. And so just before that, I was like, let's try to do this. And people were like, yeah, maybe there's some risks here. And then we had an actual cyber attack which shut down the HSE in a lot of ways. And obviously that then slowed down our process of getting this. But we still managed to get through it. And if you persevere these things, you can do it. But you really have to work at it to get there,
Peter MacMahon, Radiologist Consultants at The Matter, thank you very much for joining us on the AI Ireland podcast.
No problems. Thank you very much.
Did you know that there's over 200 podcasts on the AI Ireland podcast which showcase the best and brightest of AI being applied on the island of Ireland? If you're interested to find out more about how AI is being used day to day on the island of Ireland and abroad, why don't you subscribe to this podcast, and within 15 to 20 minutes, you'll have the opportunity to reimagine how you're seeing AI being worked in business, finance, healthcare. Outside of that, I hope you subscribe and enjoy the episodes.